Welcome. Today we are working through acute cholecystitis, inflammation of the gallbladder. For most patients, it starts with one stone in exactly the wrong place. We will follow a single patient from the emergency department to the operating room. Along the way, we will build the mechanism from first principles, read the ultrasound, reason through a hepatobiliary scan, and decide when to operate. We will also give real time to Acalculous cholecystitis, the version with no stone at all. It behaves like a different disease, and it hides in the intensive care unit. Two ideas carry the whole session. Obstruction comes first, and infection comes second, and time is what turns a swollen gallbladder into a dead one. Let us begin at the bedside. Meet our patient. Marcus is 58 years old. He came to the emergency department at 3 in the morning, with pain under his right ribs. It began about 16 hours earlier, after a heavy meal. Here is the detail that matters most. It never went away. He has vomited 4 times. He feels hot, and he cannot get comfortable. He has type 2 diabetes, and a body mass index of 34. Over the past year, he has had 2 or 3 shorter episodes of the same pain that faded on their own. Hold on to that history. Those brief attacks are the natural history of this disease. As we go, keep asking yourself what makes this attack different from the last 3. Here is what we want you to take away. First, define acute cholecystitis and separate it cleanly from biliary colic. Second, trace the mechanism from a stone in the cystic duct all the way to a dead gallbladder wall. Third, explain why only about half of these gallbladders become infected, and why that changes treatment. Fourth, recognize acalculous cholecystitis and the patients who develop it. Fifth, elicit and interpret the Murphy sign correctly. Sixth, read the laboratory pattern and know its limits. And seventh, name the 3 laboratory thresholds that should send you looking at the bile duct. Notice that most of those are reasoning skills rather than facts. Facts are easy to look up. The reasoning is what you carry to the bedside. Continuing. Eighth, identify the ultrasound findings that are specific for cholecystitis, not just for stones. Ninth, explain how a hepatobiliary scan works and why 1 in 5 positive scans can be wrong. 10th, apply the Tokyo guideline criteria for diagnosis and for severity grading. 11th, choose empiric antibiotics and justify the 72-hour surgical window. 12th, manage the patient who is too unstable for an operation. 13th, recognize gangrenous, emphysematous, and perforated cholecystitis. And 14th, know the problems that can follow the gallbladder out the door. And keep one thread running underneath everything, the Acalculous version, because it reappears in almost every section we cover. Let us take the history properly. The pain started in the epigastrium about 16 hours ago, within an hour of a fatty meal. Over the next hour, it settled under the right costal margin. It is constant, not colicky, and it bores through to the tip of the right shoulder blade. That is referred pain traveling with the phrenic nerve. He has vomited 4 times and cannot keep water down. He has no appetite, and he felt feverish at home. Now notice the single most useful feature, duration. Biliary colic almost always breaks within about 6 hours. Pain still present at 16 hours is no longer colic. Ask about previous attacks every single time. A history of short repeated episodes is often the strongest clue you will be given. Now the history that actually changes our thinking. His past medical history includes type 2 diabetes for 10 years, hypertension, and high cholesterol. His medicines are metformin, lisinopril, and atorvastatin. Socially, he is a former smoker who drinks no alcohol. His mother had her gallbladder removed in her 60s, and the review of systems gives us the piece we needed. 2 or 3 brief attacks of right upper quadrant pain over the past year, each lasting a couple of hours, each after a rich meal, each settling on its own. That is symptomatic gallstone disease announcing itself. 2 details there do real work, the family history, and the pattern of brief repeated attacks that each settled on their own. On to the examination. He looks unwell and he lies still. Moving hurts. His temperature is 38.3 degrees Celsius. His heart rate is 104. His blood pressure is 138/82. His respiratory rate is 18. His sclerae are not yellow. The abdomen is soft everywhere, except the right upper quadrant, where there is focal tenderness and voluntary guarding. Bowel sounds are present. There is no rebound and no rigidity. And when we palpate under the right costal margin and ask him to breathe in, he stops mid-breath. That inspiratory arrest is the Murphy sign, and it deserves its own slide, because it is one of the signs most often performed badly. Let us do that sign properly, because it is often done badly. Place your fingers under the right costal margin in the midclavicular line. Press in gently, and hold your hand still. Now ask the patient to take a slow, deep breath. The diaphragm pushes the liver and the inflamed gallbladder down onto your fingers. If the gallbladder is inflamed, the patient catches the breath and stops. That inspiratory arrest is the sign, not simply tenderness. The same idea works under ultrasound. The sonographer presses the probe on the gallbladder and finds the point of maximal pain. Two cautions. Pain alone without the arrest does not count, and the sign is less reliable in older patients, so a negative Murphy sign never rules this out. Here are his laboratory results. The white cell count is 15,800 with a left shift. The C-reactive protein is elevated. Those two tell us there is real inflammation. Now the liver panel. Total bilirubin is 1.6, alkaline phosphatase is 142, the aspartate transaminase is 61, and the alanine transaminase is 74. Amylase and lipase are normal, so everything is mildly abnormal, and nothing is dramatic. Keep those numbers in mind. In a few slides, we will meet 3 thresholds that would have sent us somewhere else entirely. Notice also that the lipase is normal, which makes gallstone pancreatitis unlikely on these numbers. So what are we actually treating? Acute cholecystitis is acute inflammation of the gallbladder wall. In the great majority of cases, the trigger is mechanical. A gallstone impacts in the cystic duct and will not move. Notice what that means. The problem is obstruction first, and infection second. The gallbladder is a blind pouch that has been sealed shut. Everything that follows, the swelling, the pain, the fever, the risk of necrosis, comes from pressure behind that blockage. A minority of cases have no stone at all, and we will come back to those. One framing that helps. Think of this as a compartment syndrome of a hollow organ. The pressure inside the pouch is what injures the wall. Let us put some numbers on this. First, about 20% of patients with symptomatic biliary pain go on to develop acute cholecystitis within 2 years. So those brief attacks Marcus described were not harmless. They were a warning. Second, roughly 9 in 10 cases are caused by a stone. The rest are acalculous. Third, about 10% of cases perforate, and that number is driven mainly by delay. Put those together, and you have the clinical significance of this topic. A common disease, with a predictable warning phase, and a complication rate that rewards moving early. One practical consequence. When a patient describes repeated short attacks, that is the moment to arrange an elective operation, not after the 3rd emergency visit. Let us build the anatomy. Bile leaves the liver through the right and left hepatic ducts, which join to form the common hepatic duct. The gallbladder hangs off that system by a single narrow channel, the cystic duct. Below the junction, the common bile duct carries bile down to the duodenum. Now watch what happens here. A stone slips out of the gallbladder and lodges in the neck, or the cystic duct. Follow the arrow. Bile from the liver still flows freely to the duodenum. So the patient is not jaundiced, but the gallbladder itself is now a closed space. Remember this picture when we reach the laboratory results. An open duct is exactly why the bilirubin stays low, and why a high bilirubin sends you looking elsewhere. Now the cascade. Step 1. The cystic duct is obstructed. Step 2. The mucosa keeps secreting mucus and fluid into a space that cannot drain. Step 3. Intraluminal pressure climbs and the gallbladder distends. Step 4. That pressure squeezes the small vessels in the wall, and the mucosa becomes ischemic. Step 5. Injured mucosa releases phospholipase and inflammatory mediators, including prostaglandins, which drive still more fluid secretion and wall edema. Notice the loop. Pressure causes injury, and injury causes more pressure. All of this is sterile at the start. This is also why fluids and antibiotics alone stall. Nothing in that loop is interrupted until the duct is opened or the gallbladder comes out. Here is a point residents often get backwards. Acute cholecystitis does not begin as an infection. It begins as a mechanical and chemical injury behind an obstruction. Bacteria are cultured from the bile in only about half of cases. They arrive second, after the wall is already damaged. The usual organisms come from the gut. Escherichia coli, Klebsiella, and Enterobacter species. Why does that matter? Because antibiotics treat the passenger and not the driver. Nothing truly settles until the obstruction is relieved, and that is why the definitive treatment is surgical. It also explains why blood cultures are often negative, even in an unwell patient. The infection is local, sealed behind an obstructed duct. Left alone, this follows a predictable path. First, the wall becomes edematous and inflamed. Then venous and lymphatic drainage is choked off and the wall becomes congested. Then arterial supply fails and the wall becomes necrotic. That is gangrenous cholecystitis. Pus can collect inside the sealed gallbladder, an empyema. And finally, the dead wall gives way. Perforation happens in roughly 10% of cases. Usually the omentum walls it off into a pericholecystic abscess. Occasionally it opens freely into the peritoneum, and that patient is critically ill. Notice how few of these steps depend on the organism. The wall dies because it is starved of blood, not because a bacterium is especially aggressive. Now put Marcus aside for a moment and walk into the surgical intensive care unit. This is a 68-year-old woman on day 10 after a motor vehicle crash. She had a splenectomy and multiple rib fractures. She is intubated and sedated. She has received total parenteral nutrition since admission, and fentanyl for pain. Today she has a new fever. Her white count has risen to 19,000. Her alkaline phosphatase is climbing. Nobody can localize her pain because she cannot tell us. The ultrasound shows a distended, thick-walled gallbladder, and no stones at all. Nothing about this presentation looks like Marcus, and that is exactly the problem. The disease announces itself only as an unexplained fever. So what is happening in her gallbladder? Two forces, and neither is a stone. The first is stasis. She has not eaten by mouth in 10 days. Without food in the duodenum, there is no cholecystectomy signal, so the gallbladder never contracts. Bile sits, concentrates, and becomes thick sludge that irritates the mucosa. Opiates worsen this by tightening the sphincter of Oddi. The second force is ischemia. Shock, vasopressors, and systemic inflammation shut down the microcirculation in the wall. Put stasis and ischemia together, and you get necroinflammation with no obstruction at all. Notice the last row especially. The stone disease gives you a warning phase. This one gives you almost none. Who gets acalculous cholecystitis? Almost always someone who is critically ill. The classic settings are major surgery, total parenteral nutrition, sepsis, trauma, burns, opiate therapy, and immunosuppression. Notice that our intensive care patient ticks 4 of those boxes at once. There is a second group. In immunocompromised patients, an organism can be the direct cause. Cytomegalovirus, Candida, Cryptosporidium, Campylobacter, and typhoid fever have all been described. So, with advanced immunosuppression, this may be an infection rather than a consequence of stasis. Practically, if a patient has been in intensive care for a week and spikes an unexplained fever, put the gallbladder on the list early. Why is this diagnosis missed? 3 reasons. The patient is sedated or encephalopathic and cannot report pain, so the Murphy sign is unavailable. The fever and the high white count are blamed on the pneumonia or the wound. And everyone is hunting for stones which are absent by definition. So the diagnosis rests on the picture. A thickened distended gallbladder with pericholecystic fluid in a critically ill patient with unexplained fever. Move quickly. This form reaches gangrene faster than stone disease, and the first step is usually a percutaneous drain rather than an operation. And do not wait for a Murphy sign that will never arrive. Here the imaging plus the clinical setting is the whole diagnosis. Back to Marcus. Who forms gallstones? The classic risk factors are female sex, age over 40, obesity, rapid weight loss, pregnancy and estrogen exposure, diabetes, a family history, and certain ancestries including Native American and Hispanic populations. Add ileal disease and chronic hemolysis for pigment stones. Now line Marcus up against that list. He is 58, his body mass index is 34, he has type 2 diabetes, and his mother needed her gallbladder out. He is male, which lowers his risk a little, but 4 risk factors outweigh that. One more point about diabetes. It does more than raise the risk. It also predicts the complicated forms we will meet later in this session. Let us generalize from our patient. What do these patients say? Right upper quadrant or epigastric pain that is constant and lasts more than 6 hours, often radiating to the right shoulder or around to the back, with nausea, vomiting, and fever. What do you find? Focal right upper quadrant tenderness, a positive Murphy sign, and sometimes a palpable gallbladder. Jaundice is not typical here, and when you see it, you should start thinking about the bile duct instead. The combination to act on is localized pain plus fever plus a positive Murphy sign. And remember the exceptions. Older patients and patients with diabetes can present with far less pain than the picture would suggest. This is the distinction that matters most at the bedside. Biliary colic is a stone that temporarily blocks the cystic duct and then falls back. The pain builds, plateaus, and breaks, usually within about 6 hours. There is no fever. The white count is normal, and the abdomen is not tender between attacks. Acute cholecystitis is a stone that stayed. The pain does not break. The patient becomes febrile. The white count rises, and the right upper quadrant is genuinely tender with a positive Murphy sign. Same stone, same duct, but obstruction that persisted. In practice, the clock and the thermometer do most of the work. Duration beyond 6 hours, plus a fever should move you off colic. What should the laboratory show? Expect a raised white cell count and a raised C-reactive protein. You may see a mild rise in bilirubin, alkaline phosphatase, the transaminases, and amylase. Now the warning. Do not be fooled by normal numbers. A normal white count does not exclude acute cholecystitis, particularly in older patients, and the liver panel is often completely normal because the common bile duct is still open. The laboratory supports the diagnosis. It does not make it, and it does not exclude it. One more caution. A mild rise in the transaminases or the amylase is common here and does not by itself mean the duct is involved. It is the magnitude that matters, and we will put numbers on that right now. Now the 3 numbers that should change your direction. If the aspartate or alanine transaminase is above 500 units per liter, if the bilirubin is above 4 milligrams per deciliter, or if the amylase is above 1,000 units per liter, Stop and think about the common bile duct. Those values are too high for simple gallbladder inflammation. They point to cholecystitis, a stone that has moved out of the gallbladder and into the duct. That patient may need an endoscopic procedure. Marcus is nowhere near those thresholds. This is also the handoff to the next topic in this series, cholecystitis, where these numbers are the presentation rather than the exception. Keep them somewhere you can find them quickly. Ultrasound is the first test. Always. It is highly sensitive and specific for stones, but here is the key point. Seeing stones is not the same as diagnosing cholecystitis. Many people carry silent stones, so look for the findings specific for inflammation. First, wall thickening greater than 4 millimeters. Second, pericholecystic fluid. Third, a sonographic Murphy sign. And fourth, the stone itself, impacted at the neck and no longer mobile. Marcus has all four. A wedge stone, a wall of 5 millimeters, fluid around the gallbladder, and pain right under the probe. One practical tip. Ask the sonographer directly whether the Murphy sign was positive under the probe. It is often left out of the written report. What if the ultrasound does not settle it? Follow this tree. If the study is technically inconclusive, bowel gas, body habitus, or an equivocal wall, move to computed tomography or magnetic resonance imaging. If you suspect a complication, gas in the wall, perforation, or an abscess, go straight to computed tomography. It is far better at showing those. And if the imaging is unremarkable but your clinical suspicion is still high, that is the moment for a hepatobiliary scan. Each branch answers a different question. In practice, most patients never need the second or third branch. The ultrasound plus the bedside settles it. Reserve these for genuine uncertainty, and remember that a scan you did not need still delays the operation. Here is how a hepatobiliary scan works. We inject a technetium-labeled tracer into a vein. The liver cells take it up from the blood and secrete it into bile, exactly as they handle bilirubin. Follow the normal panel on the left. Tracer appears in the liver, then in the bile ducts, then it fills the gallbladder, and then it passes into the duodenum. Now the abnormal panel on the right. Tracer enters the bile duct and reaches the duodenum, but the gallbladder never fills. There is only one explanation. The cystic duct is blocked. Notice what the scan is actually asking, not whether the gallbladder is inflamed, but one mechanical question: is the cystic duct open? That is why it is so sensitive, and also why it can mislead. How good is it? The hepatobiliary scan is the most sensitive test we have for acute cholecystitis, in the range of 80 to 90%. But between 10 and 20% of positive scans are false positives, and you need to know why. First, chronic cholecystitis can leave the cystic duct scarred and obstructed with no acute attack at all. Second, a lengthy fast leaves the gallbladder already full of thick, concentrated bile, so fresh tracer cannot get in. Third, significant liver disease impairs uptake and excretion. Always read it against the clinical picture. Notice that all three share one mechanism. Tracer cannot enter a gallbladder that is already blocked or already full. So ask about fasting and liver disease first. Let us make the diagnosis formal. The Tokyo Guidelines, revised most recently in 2018, group the findings into three parts. Part A is local inflammation, a Murphy sign, or a mass, pain, or tenderness in the right upper quadrant. Part B is systemic inflammation, fever, a raised C-reactive protein, or a raised white cell count. Part C is imaging characteristic of acute cholecystitis. The rule is simple. One item from A plus one from B makes the diagnosis suspected. Add Part C, and it is definite. Marcus has all three. Notice what these criteria do not require. They do not require a stone. They do not require jaundice, and they do not require an operation to confirm the diagnosis. Severity grading drives the plan. Grade 1 is mild, an otherwise healthy patient with no organ dysfunction and only mild inflammation in the gallbladder. Grade 2 is moderate, a white count above 18,000, a palpable tender mass in the right upper quadrant, symptoms for more than 72 hours, or marked local inflammation such as gangrene, gas in the wall, an abscess, or bile peritonitis. Grade 3 is severe, and it is defined by organ dysfunction, cardiovascular, neurologic, respiratory, renal, hepatic, or hematologic. Grade 3 changes the order of operations. In practice, the grade decides sequencing. Grade 1 and many Grade 2 patients go to early surgery. Grade 3 is stabilized first, and often drained. So what do we do in the first hours? Nothing by mouth. To stop stimulating the gallbladder. Intravenous fluids, because these patients are volume depleted from vomiting and poor intake. A nasogastric tube only if the vomiting is intractable. Analgesia, and here's a small pearl. Non-steroidal anti-inflammatory drugs are the drugs of choice for biliary pain. They work about as well as opiates, and they avoid raising sphincter of body pressure. And antibiotics, which we will cover next. All of this is preparation. None of it is the cure. And do not forget the quiet items. venous thromboembolism prophylaxis, and glucose control in the patient with diabetes. Small things, but they are the ones a busy admission drops. Who are we covering? The bile in acute cholecystitis is usually colonized by gut organisms. Escherichia coli is the commonest, followed by Klebsiella species and Enterobacter species. In sicker patients, in older patients, and in anyone with previous biliary instrumentation, broaden your thinking to include Enterococcus and anaerobes such as Bacteroides fragilis. And remember Clostridium species, which we will meet again when we talk about gas in the gallbladder wall. Draw blood cultures before the first dose whenever the patient looks septic. One nuance: routine Enterococcus coverage is not needed for most community-acquired cases. It matters in healthcare-associated disease and in transplant patients. 2 reasonable empiric approaches. The first is a second or third generation cephalosporin, or a fluoroquinolone, combined with metronidazole for anaerobic coverage. Ceftriaxone plus metronidazole is the everyday example. The second is a single broad agent, piperacillin tazobactam, which covers the gut organisms and anaerobes together, and is the usual choice when the patient is more unwell. Always check your local antibiogram and your institution's protocol. Resistance patterns differ by hospital, and empiric choices should follow local data rather than habit. And keep the course short. In uncomplicated disease, antibiotics are usually stopped soon after the gallbladder comes out, rather than continued for a fixed number of days. Now the highest yield decision in this topic. When do we operate? Laparoscopic cholecystectomy within 72 hours of symptom onset is preferred over waiting and operating at 7 to 10 days. Why? Because in the first 3 days, the inflammation is edematous and the tissue plane's still separate. After that, the tissue becomes dense and fibrotic. Dissection is harder, and the risk of conversion and of bile duct injury climbs. Early surgery also shortens total hospital stay. Notice that the clock starts at symptom onset, not at admission. One more consequence. If the patient first presents on day 5, early surgery is no longer early. Many surgeons then treat medically and return in about 6 weeks. What if the patient is too unstable to operate? You still have to relieve the obstruction. There are 3 routes. Endoscopic ultrasound-guided transmural drainage, which places a stent from the stomach or duodenum directly into the gallbladder. Endoscopic retrograde cholangiopancreatography with transcystic duct drainage, which passes a catheter or stent up through the cystic duct. And percutaneous cholecystostomy, a drain through the skin and liver bed, avoided if there is ascites or coagulopathy. Then operate later once the patient recovers. One caveat: a drain treats the attack. It does not treat the stones. So plan the definitive operation before that patient goes home. One more decision before the operation. Does this patient also have a stone in the bile duct? 3 findings should make you look: jaundice, cholangitis, or a duct stone seen on ultrasound. In those patients, obtain an intraoperative cholangiogram during the cholecystectomy, or arrange an endoscopic retrograde cholangiopancreatography. The point is to avoid leaving a stone behind. A retained duct stone can present days later with pain, jaundice, pancreatitis, or frank cholangitis. Marcus has none of those 3 findings, so he needs neither. One more trigger to look: a dilated common bile duct on the ultrasound. A duct wider than about 6 millimeters deserves a second look, even when the bilirubin is normal. Now the complications. Gangrenous cholecystitis is necrosis of the gallbladder wall. The blood supply fails behind the rising pressure, and the tissue dies. From there, the 2 risks are empyema, pus filling the sealed gallbladder, and perforation. Who is at risk? Older patients, patients with diabetes, patients who present late, and patients with a very high white cell count or marked systemic upset. Be careful here. The examination can mislead. As the wall becomes necrotic, the local signs can seem to soften, even as the patient gets sicker. This is also the group where a percutaneous drain can buy time, but the definitive answer is still removing a dead organ, so involve surgery early. Emphysematous cholecystitis is different, and it is an emergency. Gas-forming organisms infect the wall, classically Clostridium species and some strains of Escherichia coli. The finding is air inside the gallbladder wall. The typical patient is older, often male, and very often diabetic. A large proportion of these cases are acalculous. Ultrasound can miss the gas, so computed tomography is the test that makes this diagnosis. Treatment is urgent. Broad antibiotics with early surgery or drainage, because this form reaches gangrene quickly. One recognition tip: a plain abdominal film may show gas outlining the gallbladder, but do not wait for that film. Go to computed tomography. Perforation complicates roughly 10% of cases, and the driver is delay. Delay in presentation, delay in imaging, or delay in reaching the operating room. There are 3 patterns. Most commonly, the omentum walls off the leak and a pericholecystic abscess forms. Less often, the gallbladder ruptures freely into the peritoneal cavity, which produces bioperitonitis and a critically ill patient. And occasionally the perforation erodes into adjacent bowel and creates a fistula. All three are arguments for treating early rather than watching. And one clue at the bedside. A patient whose pain suddenly eased and then spread across the whole abdomen may have just perforated. A brief improvement is not always good news. Finally, the gallbladder comes out, and a few problems can follow it. A bile leak from the cystic duct stump or from a small duct in the liver bed. A bile duct injury, uncommon, but the most serious of the group. Retained stones left behind in the duct, which present later with pain or jaundice. A cystic duct remnant that still contains a stone. And sphincter of Oddi dysfunction, a functional cause of ongoing biliary type pain after surgery. If a patient returns with pain after cholecystectomy, work through that list. And name it carefully. Persistent biliary type pain after cholecystectomy is often called post-cholecystectomy syndrome, but that is a description, not a diagnosis. Go looking for the cause on that list. Let us collect the traps. First, a normal white count and a normal liver panel do not exclude acute cholecystitis. Second, stones on the ultrasound do not diagnose it. Look for wall thickening, pericholecystic fluid, and a sonographic Murphy sign. Third, antibiotics are not source control. The obstruction still has to be relieved. Fourth, in a critically ill patient with unexplained fever, think Acalculous disease early. Fifth, cross any of the 3 duct thresholds and go look at the duct. And sixth, a soft abdomen in a sick older patient can already be gangrene. Every one of those is a delay in disguise, and delay is the single variable that turns this from a routine admission into a complicated one. Back to Marcus. Assessment. A 58-year-old man with a year of biliary attacks now presenting with 16 hours of constant right upper quadrant pain, fever, a positive Murphy sign, a raised white count, and an ultrasound showing an impacted stone, a wall of 5 millimeters, and pericholecystic fluid. This is acute calculous cholecystitis. Tokyo grade 1. Plan. Nothing by mouth, intravenous fluids, analgesia, ceftriaxone and metronidazole, and laparoscopic cholecystectomy today, well inside the 72-hour window. His liver panel does not justify an endoscopic procedure. Notice how little of that plan is medicine. The fluids and the antibiotics are support. The operation is the treatment. Let us bring it together. Acute cholecystitis is obstruction first and infection second. A stone in the cystic duct raises pressure, injures the mucosa, and only then invites bacteria, in about half of cases. Pain beyond 6 hours with fever and a positive Murphy sign is the clinical picture. Ultrasound looks for wall thickening, pericholecystic fluid, and a sonographic Murphy sign. The hepatobiliary scan is the most sensitive test, but is falsely positive in up to 1 in 5. Operate within 72 hours, and never ignore acalculous disease in the intensive care unit. If you keep one sentence, make it this: a stone that stayed is a gallbladder under pressure, and pressure kills tissue on a clock. Those are the sources behind this session. The diagnostic criteria and the severity grades come from the Tokyo guidelines. The timing of early laparoscopic cholecystectomy follows guidance from the Society of American Gastrointestinal and Endoscopic Surgeons. Antimicrobial selection should always be checked against your local antibiogram and your institution's protocol. Thanks for working through this one. The next topic in this series follows the stone one step further, out of the gallbladder and into the common bile duct. Take the mechanism with you more than the numbers. A gallbladder that cannot empty is a gallbladder under pressure, and everything else in this session follows from that one sentence.